Okay, so the last of the working groups to present today is the Care and Treatment Working Group, and Marina Klein and Curtis Cooper have led this group, and I'll pass it over to them.
Great. Thanks. All right, so I think what's really interesting, about today so far, and I think you'll see through my presentation, is that although we've treated each of these kind of pillars from prevention to diagnosis to treatment as being separate, the conversations we're having are actually a lot about the integration in that. For example, a lot of what we just spoke about in terms of diagnosis really was about linkage to care and treatment, and we actually focused a lot on linkage to care and treatment. So I guess we'll get to continue that discussion now. Just to frame things, this is taken from the nice infographic that CanHEP-C put together about a year ago as a way to kind of sensitize at least our federal partners about the epidemic in Canada. And so it's nice because it has various people, but we're talking about the end of that cascade here. That's the few people in white at the end who've ever been treated. And the reason I think it remains important, treatment isn't just about the prevention aspect, because we spent a lot about trying to eliminate Hep C and the potential for hepatitis C as treatment as prevention. It has individual benefits that people who are living with hepatitis C can have, and that is that it will reduce their progression to serious events, liver events, death from liver disease, liver cancer, and other events, and possibly a lot of other symptoms that might be related to hepatitis C. And so we can see that these are sort of the projected rates of disease in Canada should we do nothing. And this are based on PHAC numbers from 2009. So looking at the rise, and you can see where we are now, we're in a kind of flat level high peak, and Mel's data and others will come out to suggest that hopefully that peak is going to be bent down. I would just caution to say that a lot of the people who were very ill with cirrhosis because they were infected 30 years ago have unfortunately passed away, and that's why some of that death from cirrhosis DAAs may look better because we're treating healthier and healthier people with DAAs, and they're not likely to have a liver event in the near future, so it might look better than we actually see. But never to say, there's a lot of data out there that supports the benefits of hepatitis C treatment for preventing liver disease-related deaths. So just a couple other slides to point out that treatment as prevention is a good thing to contemplate with hepatitis C. But if we think about infectious diseases globally, we have failed to eliminate virtually any infection, with one exception, smallpox. And that's even with good vaccines. So look at hepatitis B. We have an excellent vaccine to prevent hepatitis B, and we're woefully behind in eliminating that viral infection. So what's different about hepatitis C? Well, hepatitis C is a bit different in the sense that we can cure this infection. It's one of the first viral infections that we can actually cure, and it has no known animal reservoir. So there's reason to think that we can do this. We do have excellent diagnostic testing, and we've had, there are caveats to which, what tests are the best tests, who should have which tests and which are most acceptable. But we do have good diagnostic tests, and we have Jordan's Perfectivir now, I think pretty much close. So years ago, I picked this lovely golden tablet as, we have a treatment that's now very short. Probably we need to get a little bit shorter. If you look at most of the data, adherence to treatment wanes after about 4 weeks. So if we could get treatment that's 4 weeks long, we probably could get pretty much 100% cure rates in people who get prescribed a treatment. Okay, so we're talking here about the end of the care cascade. And again, I point out that these are the ones where we're actually really quite behind. Even in Canada, we estimate there's probably, this is from the BC testers cohort data, Naveed, that maybe 7, 10%, 12% maximum of people have been treated and cured overall, right? It's pretty low. Okay, so our group came up with some key objectives, and I put 2 in red here because they kind of overlap with some of the previous talks. First is this linkage question, so increase the number of persons who are diagnosed with hepatitis C that are linked to care. Second would be to increase the number of hepatitis C infected patients who initiate DAA treatment. And the consequences of that, we hope, would be to reduce the prevalence of chronic hepatitis C and reduce the incidence of acute hepatitis C. So that's a prevention swing back. And finally, to reduce the consequences of chronic hepatitis C infections. That would be mortality as the easy one to measure, but also morbidity. I think healthcare-associated costs. There's a bunch of other ones that we didn't actually go into great detail, but I think we could consider. So we took the more traditional approach than the Mel approach, which I think was actually a very good way to frame the discussion, though, Mel. And that we did come up with targets along the WHO lines, because I think we were thinking about how we can actually have some measurable things. So these aren't these aren't made up. These are along the lines of what Julie presented earlier, and along the WHO. That 50% of those diagnosed would be linked to care by 2020, and 90% of those diagnosed could be linked to care by 2030. So linked to care, and I think I take from the previous discussion, it's not just linked to treatment, it's linked to care. So, and clearly there's circumstances whereby people who are infected with hepatitis C may have many other health issues that need to be addressed, or addictions issues that need to be addressed. So the linkage step for me is actually more than just about getting someone treated. It's about being able to address those other issues that are present, and it fits in with a syndemic sort of approach. So I think we're not doing too badly if we look at what data we have. We really have very little data about this. So I kind of made an extrapolation from the BC testers cohort that 35% have been genotyped. So that could be a surrogate as linked to care. That was in, maybe it's old data now, but it's probably gone up. What is, I don't know, you can tell me if it's higher now.
Yeah, it has increased quite a bit.
Yeah. So, but for me, that means that they've gone an extra step, because you don't get a genotype test ordered unless you've seen someone who has some knowledge about hepatitis C. So that's at least an opportunity to have seen a health professional who knows something about hepatitis C. So we probably can be getting close by 2020 to the 50% target. I think that's not. How do we get to that 90% target, I think, is some of the stuff that Mel was talking about. Okay, what about objective 2, treatment initiation? So this is very much along the WHO guidelines, 30% of chronic hepatitis C treated by 2020. And so we did some, again, these are sort of back of the envelope calculations, which is unfortunate because this is the data that we're working with. So it gets back again to Julie's need for surveillance and good numbers. So if we estimate that we could get to about 68,000 people living with hepatitis C in Canada by 2020 if we reduce the number of people by 30%. That would mean we'd have to treat 34,000 people a year for the first 2 years, because we only have 2 years to get to 2020. And then to get to our good target of 80% by 2030, we'd have to treat on average an additional 15,000 person per year. So I don't know, this is again based on the number that has been estimated to have already received treatment and cured, and extrapolating that to what we think is the prevalence of chronic hepatitis C in Canada. So these are ballparky, but it's a substantial increase in where we are right now. To reduce prevalence, this is basically the numbers are similar, 30% reduction in prevalence and 90% reduction by 2030. So that would mean assuming that these treatments are curative for the most part, which they are. I think we have good real world data now to suggest that there's at least 95% cure rates in most circumstances. And this hopefully will lead to reduction in incidence, so the same sorts of targets. And we've put estimates on the number of new infections per year that this could mean. And I think here we need to look at where our numbers come from again. So these are based on quite old estimates about how many new infections there are a year. I don't know if we have better data that we can support this with. There aren't really great data about this. And I think this is a big problem for us because we have no idea how to measure this as a target if we don't have good baseline data. And finally, objective 5 was to reduce HCV-related mortality. And so that is a 10% reduction in the number of deaths by 2020. And again, we have really poor data here to go on, and 65% by 2030. So if you look at the data that we have on the national, from CIHI on the national numbers of deaths that are attributed annually to hepatitis C, it's only 346, which doesn't seem to make sense given other estimates that we had from modeling. We've had estimates from modeling exercises that there should be about 1,500 deaths per year due to hepatitis C. That should be 2016, not 2106. I don't know, I was typing fast. And nearly 2,000 by 2026. So we really need more data. And I think the reason here is that people don't attribute the different deaths to hepatitis C when it could have been related. Okay, so then in terms of our suggested activities, moving along quickly, we had linkage to care. So I think we spent quite a lot of time already discussing linkage to care, and we support some of the same types of ideas that came up. Access to rapid or simplified diagnostic testing to facilitate screening and confirmation, which is paired with access to counseling for those found to be hep C positive and referral to a provider. So somehow linking those two actions together. Reducing the time of linkage to care for those diagnosed by simplifying the referral pathways and eliminating the need for additional tests and unnecessary appointments. So some of that is that reflex testing. Some of that is just not having to someone come in and say, oh, okay, you had a positive test, let's repeat everything again, and then come back again in 2 weeks, and then people get fed up with the system and the time it's taking. Reduce the time between treatment decision and start of therapy. So this is one place where we could actually institute action. In HIV, we've moved to trying to do things as like same-day treatment. We had some discussion and controversy about whether this is at all advisable, feasible, or possible in the Canadian context. Currently, since there's quite a lot of paperwork that can go is involved in getting reimbursement for treatment, it's probably at the current time impossible. Ultimately, if prices continue to fall and the restrictions are removed from who can be treated, it might be possible to have a prescription for treatment, just like you have a prescription for antiretrovirals, and then that could occur in a very short period of time. But at the moment, we're stuck with the functioning. But there could be facilitated ways of speeding that process up, since almost everyone will be eligible for treatment in the near future in Canada. And obviously, re-engagement of those previously diagnosed but lost to care and into treatment, and that's probably the most challenging because how do you identify those people? How do you if they don't want to be re-engaged, how do you deal with that? If they do want to be engaged but you can't contact them, how do you do that? So those are the challenging areas. Objectives 2 and 3 are kind of linked together because obviously if you initiate people and cure them, you're going to reduce prevalence. So we have a bunch of different things that we brought up here, starting with education. And part of the idea is that I think there's still room for enhanced education amongst people who are affected by hepatitis C, among people who are caring for people with hepatitis C, about the benefits of diagnosis, about the benefits of treatment but they have to be very population specific and they have to be culturally sensitive. And I think we haven't done a really great job at that. But this extends to care providers too, who don't even think that it's an urgency, or why should I treat this person because they're just going to die from something else, or there's all sorts of attitudes that are out there that really still need some work. I think there's also some importance of about adherence to treatment. As long as we have longer treatment courses, I think understanding the need to complete treatment, just like we do in infectious disease generally about finishing your course of antibiotics, because resistance is not a problem currently. We don't think it's going to be easy to become resistant to most of these drugs, but it's not an inevitability. That's a double negative, but we always thought, we think that with certain drugs that never will happen, but then it does. So, okay. Capacity. I think capacity is a problem in this country. People do have to wait a long time to see someone who can treat them, or they might have to wait a long time to see someone who could treat them but doesn't want to treat them because they aren't comfortable with the community from which those people come from, or it's nowhere near where they live. And so I think educating a broader range of providers regarding management of hepatitis C and addiction. So an interesting survey that one of my postdocs just did as Can Hep C was doing a survey of infectious disease providers in Canada. And surprisingly, there was a very high rate of agreement about the need to treat people who use and inject drugs and the desire to treat those people, but a very strong desire to have more education about management of addictions and comfort with working with people with substance use issues because they didn't feel able to do so. And that was an impediment for taking on hepatitis C treatment. And I think if we ignore the fact that these two things are quite tied, it's going to be hard to engage more providers outside of the standard ones to be involved. We've already heard about involving nurse practitioners, point of care testing and treatment in OST clinics and other scenarios. I think we have to look at a broad range of experts that could be involved, and to increase capacity and support for treatment in these low threshold settings where people may feel more comfortable to come. There are still barriers to treatment that are jurisdictional in this country that are coming down with the reduced pricing of the hepatitis C drugs. They're still expensive, and we still are going to need to have pressure to have competition and other means to lower those prices further if we want to be able to make the points that retreatment of people who become reinfected should be the rule. And we need more transparency in these negotiations so that people can understand what the price. I don't even know what the price actually is. I don't think anyone in this room really knows what the price actually is. How is that possible in a public payer system where we don't know what we're paying to treat? And how can we make balancing decisions about where resources should go if we're putting a huge pocket of money into pharmaceutical companies? Linkage of remote patients to hepatitis C treatment, telemedicine types of programs. These have been well tested and work. Mobile programs are another way of doing this. There could be other innovative strategies, but in Canada, this is a reality, and I think we have to think about how we can do that better. Develop pathways to link incarcerated persons to care upon release, and I think this is particularly true for the provincial setting because the turnaround time can be very rapid. So the time from someone can be tested and be discharged or put on remand before they even get the test result back. And then they may be reincarcerated even before they would have had a chance to be connected to care. So there needs to be some novel ways of linking people upon release to get their results or to get treatment. Okay, I don't want to use up all the time, but we have a few more. Strengthen and modernize multidisciplinary approaches to care. So again, this gets back to syndemics, that really we're talking about tailored care models that meet the needs of the priority or key populations. And we might think more broadly about incorporating peers where this is appropriate. And we're going to have to work with the provinces and territories who actually are responsible for financing these regional centers, where there are lots of centers with lots of expertise, either in the care of HIV addictions or hepatitis C, that have built expertise that could actually, in a sort of hub and spoke type of model, maybe deliver that care quite efficiently without having to really train up a whole bunch of new providers right now, which could take a lot of time. So we should try to maximize the resources that we already have developed and make sure that they continue to be resourced. And I think we've talked about the syndemics view of integrating care with substance, alcohol misuse, mental health, and social services. Housing and food security, I think, come up time and time again as issues that the populations face and interfere with our people's ability to engage in treatment or even prioritize treatment for themselves because they have too many other competing issues. We have lots of burgeoning e-health systems all over the country, and they're all different, and none of them talk to each other. And this is a big challenge, but they also harness, there's a whole potential there that we should try to harness where we can. Okay, and then objective 4, reducing incidence, so this comes to prevention, is really the follow-up. So we talk about treatment as if it's the end game, and there's lots of people saying, okay, after you've had you don't even need an SVR check anymore because you're going to be cured, so you don't even need to come back. And it doesn't really make sense if we think about this whole syndemics approach as a way of engaging people into care as a big care package, that we don't continue to monitor for recurrence of infection, reinfection, and other risks that are happening. And so we recommend testing of at least every 6 months for those who may continue to be at risk. And the reason isn't there to identify those people as bad people because they got reinfected, but to offer treatment again. Because if you think about people becoming reinfected, they are engaging in practices that expose them and expose others to hepatitis C. So if we want to talk about elimination, we need to actually retreat as quickly as possible to reduce the HCV RNA that's floating in the community. Pair hepatitis C testing with STI testing in high-risk MSM, in particular, if we talk about key populations. And as we reduce the number of acute and chronic infections over time, we're going to need some more surveillance, and it links back. I don't know about this as a way of doing this, but it's quite controversial. But we can use data that we have through phylogenetics to look at clusters and to see, not necessarily target individuals, but target regions or areas where we should go in and, and help, support, and look at what are the underlying factors that are driving continued infections in certain areas. And finally, in reducing mortality, we have to remember that people who are living with hepatitis C now who have advanced fibrosis, actually, although they have been prioritized for treatment in terms of the guidelines and reimbursement, still a large number of them have not yet been treated. And we need to prioritize those people for treatment because they're the ones who have immediate benefit and reduce risk of outcomes. We need to also continue to monitor people with cirrhosis after they've been cured to make sure that they do not develop complications such as cancer. And then develop treatment options for those few people who are unfortunate not to respond to any of our current treatments Okay, and so we did look at the key populations throughout this. I think I've sort of touched on all these as I've gone through, so I can just leave those up. I don't think there's anything in there that I've said that's that different. I think there might be certain communities, in particular Indigenous communities, where we really have to think about community-based models of care that are much more holistic and engage in Indigenous wellness approaches that might not be focused on treatment per se, but focused on health as a whole and harm and reduction of harm in general. And the same goes for people who use drugs in terms of novel models of care that can involve direct peers and case management and other things that have been actually tried and shown to work in many places in the world. So I'll stop for comments. Yes. Your job.
This is my contribution.
Keep me hydrated.
That's the purpose. So Julie,
Everyone should
Bruno,
have a good co-chair so they can get water.
I think through all these presentations, and I think the treatment one is the more obvious, is we balance between the holistic care and doing everything, and then the treatment, access to timely treatment, etc. Obviously, working with people who are using drugs, and it's always the balance between, because in a way, my plea is at the end, we have to address this very clearly, otherwise it's going to be confusing and it may put our document in all directions in a way that people say, okay, do they want us to prioritize, let's say, the John Dillon model, which is you go at the pharmacy, you get your treatment, and you have like your cure of your Hep C, and by the way, we'll treat the other thing because we cannot do everything? Or we have such an holistic way of looking at all the competing needs that the Hep C is a part of it, and it can be a little bit buried into it, and then we lose the focus. I don't obviously have the solution, but I think we have to think it through when it comes to the end document, that it's clear where we stand, and we can try to do everything and say that we should do everything. At the same time, when we focus on Hep C, we have also to know where we stand in the middle, one place or the other.
Yeah, I think it's a really good point, Julie. So I think that's why we have the targets are sort of hard, and then we have the actual operationalization of those targets is actually more an syndemic sort of approach. And I think that also, remember that we all started this whole exercise with trying to respond to the strategy document. I can't get the right name for it. I don't want to say the wrong one, but that where we're aligning ourselves with what the PHAC strategy document looks like. And so we're following along sort of that more general holistic one with some HCV specific elements, recognizing that HCV is not happening in isolation. It's just not. And so I think we're going to have to find some balance somewhere, and it might be a little tricky sometimes. Yeah.
Since you just brought up the John Dillon model of care, we need to be a tiny bit careful about all aspects of the model. There was a poster at EASL in the part where they were treating at needle and syringe programs, where the cure rates were high, but the reinfection rate was like 20% within a year. So I think we just need to be, the post-treatment care will become important. Coming back to the whole issue of being a blueprint and availability of medicines, and if we want to be forward-looking, this is a unique opportunity for us to endorse the idea of a national pharmacare program that will begin to address a whole bunch of the issues that you raised about access to the medicines and so on. And this is the kind of document where this argument can be made. You can point out all the problems that we currently have in accessing the treatments, interprovincial, interterritorial disparities, the copays, and all of those types of issues. And if you're to achieve the ambitious but realistic goals that you did put forward, it'll require that barrier to be removed. And since current government is embracing national pharmacare, it's a good time to tell them they're doing the right thing.
Good idea. Very good idea. I support that.
I guess my question, and Dr. Cooper, maybe you can add your input too. Within the community, obviously no financial limitations, right, around treatment. There's options for people to get the treatment covered. When you're entering a provincial setting, if you're on OW or ODSP, your ODB card, your Ontario Drug Benefit Card, is actually suspended upon incarceration. So when we're talking about funding and we're talking about the price of treatment, how are we addressing the financial limitations that are still existing within our provincial system for people that are trying to access treatment?
So it's excellent, and it's an important point. And although we, at least in Ontario, we've made some tremendous steps forward in reducing the paperwork, and it actually is possible to write a prescription same day in the clinic for some people. That's actually not the case for the majority of our patients. They still have to apply to Trillium if they're working, and it's a big issue if you're the working poor. And it's just even more complex if you're incarcerated at the time. So these are issues that absolutely have to be written into the documents.
And I'm not sure, maybe it's just good to know, I just can't remember when you're going to be presenting the blueprint, just because, as of July 1st, there is going to be a report that's submitted to the government in regards to recommendations on if the Ministry of Health should now be overtaking healthcare within corrections, right? Because, and correct me if I'm wrong, just from my experience, that people that want to access treatment at the provincial level, it's really not your choice. It's the choice of the institution if they want to pay for your treatment or not. So how do we get around, again, other people making decisions for the patient in regards to financial, in regards to, are you a good candidate from the provincial setting that I'm going to pay for your treatment within that setting, right? Also, I don't want to get hung up sometimes on the short stays, right? I don't want to get caught up on that stuff too much, because even if you were talking about care plan, that if somebody's being released in a short period of time and they weren't able to get their diagnosis back, but they have no housing, they have no money, they're actively using drugs, mental health concerns, most likely they're going to end up back. So that's another opportunity for more linkage to care, that you could actually deliver the diagnosis if we had medical records in the institutions, that we could keep track of all that stuff, and then it can just be continuous. Again, as I said, it's not about limiting number of visits, actually about increasing number of visits, sometimes in that population.
Yeah. So, I mean, my own personal philosophy with our viral hep programs, work with the local correctional service, is the goal isn't to treat everybody while they're incarcerated. Our primary goal is to make a linkage with them, so that once they're released, that'll continue, so that at some point we can get them engaged in Hep C treatment and lots of other stuff that we've all discussed this morning.
One more super quick point too is just with that short stay too. The reason why I don't want to get hung up on that is because initially, if you're waiting for trial, you're waiting for bail, that could be a month, it could be 3 months, it could be 4 months, it could be 3 years. So sometimes I don't want to get stuck in this short stay of no treatment because you don't have a release date, when realistically you could be sitting in that institution for 2, 3, 4 years, 8 months, where there is enough time to actually process and to go through that treatment.
Yeah.
Waiting for trial and bail and stuff like that, and appeal of bails. Like, there's so much.
Yeah, no, of course you're correct. If you can be confident that linkage is going to be there, then I'm more confident that that we can start the Hep C therapy while they're incarcerated, and continue that whenever they happen to be released, which, as you know,
That's
can
fair.
happen quite suddenly and without much forewarning.
That's actually fair, and I think that's cool. If you can guarantee a linkage to care, even if you might be there for a short stay, that can. But it's the education that must come from you to the person inside, explaining how important it is to continue the 1 day appeal, and it's like you have to give them that choice, right?
Yeah.
And you have to give them that education so they understand the importance of the process.
Yeah. No, it's all part of setting people up for success when
Totally.
you start on therapy, and that's the education, that's the linkage, that's the supports with all the other stuff that's going on in their
That's
lives.
cool. Thank you.
Yeah, just to say, it's not just Ontario where that issue is arise. I don't know if it's true in other provinces, but in Quebec, the Hep C treatment comes out of the provincial budget, provincial jail budget for provincial prisons, and so they don't actually. It's too much for their budget, so they don't treat. Yeah. No one gets treated in prison unless it's through an outside linkage.
Hi, I just want to say it's really good, I think, to see some of these targets that are related to the cascade of care. I think, it's enormously challenging because the targets are very simplistic and they don't really get at the idea that there's going to be differences in populations and what people want. But it really gives a way for us to kind of look at it at a systems level. And it also helps to sort of advocate for where things are falling short and to kind of keep focused over a long period of time on what we're trying to achieve. So I just want to say that I think this is really quite important, and it's great to see these targets in the strategy or in the blueprint.
Hi again. From what I've heard during this and other sessions, and from looking at the framework and thinking about the blueprint, maybe we ought to think about where hepatitis C fits within a circle of care, almost in a diagram, like this is a circle, and where these parts, I'm seeing maybe something a little color-coded, and the cascade is very useful in some ways, but if we're talking about keeping people linked, it is really more like a circle because it doesn't end when they're cured. So that's why I thought maybe like a circle that's nested into around the pillars of the framework. I sort of got this idea of a Stonehenge type structure. So I don't know. I'd be interested to hear people's thoughts, perhaps after lunch.
Stonehenge.
Yeah, so I could just comment on that. So the cascade of care that we created for education development purposes, that was a continuous circle. Like you have post-treatment related follow-ups for reinfection as well as for HCC and other care needs like for alcohol and so on. And then it's also pre-diagnosis related pieces as well, related to prevention as well. And it is a kind of a circle. But when it comes to data points have been like very difficult piece, and that's where like it was more of a linear piece, mainly focusing on diagnosis to treatment and SVR. But as we are collecting more data and becoming more nimble, I think we should be able to add more pieces to it, and that would be required. And just one of the point related to cascade. So we have like the overall cascade in BC. We were able to do cascade for various population groups, like people who inject drugs, HIV, and immigrants, and then by socioeconomic status and so on. So again, if you have these integrated data platforms, they allow you to create these cascade of care by various population groups. There are always challenges in terms of like how accurate some of these definitions are and so on, but it's better than nothing. So that's what we need to advocate for as well.
Anybody else want any more water?
Before Chris's job is done. Thanks, everybody.